Welcome everyone, good afternoon. I'm Dániel Bednárik, and let me introduce to you my PhD topic, which is therapeutic strategies in Clostridium as difficile infection. A few words about me. I'm a resident doctor in Heim Children's Hospital and a PhD student. My supervisors are Kata Lenti and László Földvári Nagy. My SMS is on a trans, my statistician is Noemi Gede. In the first project, we're comparing the effectiveness and safety of different therapies in C. diff infection in adults. A few words about the background, why is it a hot topic? So this is the most common healthcare associated dire worldwide, from 20 to 27% caused by C. diff. And almost 500,000 cases were registered among adults and children, and there were more than 10,000 deaths. Our clinical question: which is the best therapeutic option for C. diff infection? We did our systematic search with these final search key in the 3 main databases, and at the end we've got 111 eligible full text for the data extraction. So let me introduce to you our main endpoints. This is the cure rate, the recurrent rate, and the prevention. Today in this presentation I will show to you the cure rate globally, and as in subgroups, the recurrent and non-recurrent cases separately too. So we did a network meta-analysis, so let me introduce to you our first network plot in the case of cure rate. There are knots and edges on it. Every knot represents here different kind of therapies against C. diff infection. The bigger knot means that treatment was included in more articles like the others. So for example, here vancomycin was included in the most. Every edges show comparisons among different kind of therapies against C. diff infection, and the number above it represents how many articles included these comparisons. For this analysis, we included 16 interventions from 28 studies, and a little bit less than 5,000 patients were included for it. So, related to this network, we investigated here the cure rate of different kind of therapies against C. diff infection. As a clinician, it's a really important outcome how effective our therapy is. In this league table, the possible treatments are in the blue bars, and they are arranged in descending orders according to P-score. In the area above the blue bars, there are the direct comparisons, while below it, the direct and the indirect one pulls together. Odds ratio is given in the cells. We compared one treatment from the left with one treatment from the right, and it indicates how greater the chance of recovery. So for example, if we compare FMT and fidaxomicin, in the FMT arm there is almost 6 times higher chance of recovery like in the fidaxomicin arm. The confidence interval is shown in brackets. If both elements are greater than 1, in that case the result can be said to be significant. We mark these here with orange. According to our league table and according to the fact, FMT is mathematically significantly better like the other treatments, and the fact FMT's P-score is also significantly larger like the other treatments one, it suggests that in the case of globally C. diff infection, the best possible treatment is FMT treatment. But let's see what's the situation in the subgroup. So let me introduce to you our first subgroup, the recurrent subgroup. For this analysis, we included only those studies which included patients who suffered from a recurrent C. diff infection. For this, we included 11 interventions from 10 studies, and more than 2,200 patients were included for it. This is a league table, and FMT became the first in the row. If we compare FMT and fidaxomicin, for example, in the FMT arm there is almost 8 times higher chance of recovery like in the fidaxomicin arm. According to our league table, FMT is mathematically significantly better like the other treatments, and according to the P-score, which is FMT's P-score also significantly larger like the other treatments one, our analysis suggests that in the case of recurrent C. diff infection, the best possible treatment is FMT treatment. Now let's see what's the situation in the other subgroup, the non-recurrent subgroup. For this analysis, we included only those studies which included patients who suffered from a non-recurrent C. diff infection. For this, we included 12 interventions from 17 studies, and more than 2,400 patients were included for this analysis. Fidaxomicin became the first in the row in this league table. We can say about this league table, most of the antibiotics and FMT are mathematically significantly better compared with placebo, but among antibiotics and FMT, there is no mathematically significantly difference. However, according to the league table and according to the p-score, our analysis suggests that in the case of non-recurrent C. diff infection, the chosen one treatment is antibiotic treatment. But in the case of non-recurrent C. diff infection, the FMT became the first in the row, so we did a subgroup analysis to find out which is the better therapy, the colonoscopy way or the oral way treatment in the case of FMT. In the first plot, you can see 3 articles which investigated this directly. All of them are CTs and they researched the cure rate. The risk ratio is 0.10, which means that there is 1% difference in the recovery rate, which is neither mathematically significant nor clinically relevant difference. In the second plot, we investigated what percentage is the chance of recovery. The recovery in the colonoscopy arm is 85%, and in the oral way, it's 84%. Which is, so here the difference is also 1%, which is neither mathematically significant nor clinically relevant difference, but therefore further RCTs are needed to find out which method is more effective. Our analyses have strengths and of course limitations too. Let me start with the fact we included only RCTs for our analysis. The large number of the included articles and the huge number of patients who were included for this analysis, we've got multiply endpoints. But we've got limitations like the big heterogeneity of the population. In the studies, the therapeutic doses, the lengths of the treatments, and the follow-up times not completely the same. And we've got moderate and high risk of bias in some of the domains. Our main conclusion, FMT is statistically significantly better therapy in recurrent C. diff. So we've got implications for practice. First, in recurrent cases, use FMT, and in non-recurrent cases, use antibiotics first. We've got implications for research too. In the field of non-recurrent C. diff infection, further examinations needed with FMT therapy because in the field, in the literature, there is not enough. And secondly, in the field of recurrent C. diff, further RCTs needed to find out which FMT method's better. Our manuscript is nearly finished, and we would like to submit it at the end of this winter. Now let me introduce to you my second project, which is comparing the effectiveness and safety of different therapies in C. diff infection in pediatric patients. A few words about the background. It's more or less the same like in the first topic, but let me highlight a few things. So, according to the latest data, which was from the previous year, there were around 20,000 hospitalized children who suffered from C. diff in the EU, and the number of cases are growing and growing. And this is the fact why is it a hot topic nowadays. And the other thing which is really important, this illness among pediatric population is really important and common in those population who suffered any other underlying diseases, so spend a lot of time in hospital. So for them, it's really important to get the chance to give them the best possible treatment. Our clinical question, which is the best therapeutic option for C. diff infection? For this, we use the PICO framework, and our hypothesis is FMT is superior therapy for C. diff infection in children too. We did our systematic search with this final search key in the 3 main databases, and we've got more than 10,000 hits. After the duplicate removal, we've got a little bit less than 8,000 articles. Now the title and abstract selection is ongoing, And for summary, we would like to finish our first project in this year, February, and the second one in the end of this year. And the end, thank you for your kindly attention.
Thank you very much. Do you think that the current guidelines for C. diff treatment should be changed based on your results?
So the current guidelines, which if I'm right, the American one is from 2022, if I'm right, so suggest that in the case of recurrent C. diff, they recommended, by the way, the FMT treatment. So I think it's rather a new additional information for it. And the main question, I think, rather later, the situation in the non-recurrent cases with the FMT, because there is really, really few articles in the field nowadays. So, yeah.
And one more question, that who should be the donor? And should we repeat the FMT or not?
It's a really good question, by the way. So it's really strictly in the Western countries, at least, who can be a donor. So there are a lot of criteria for it. But yeah.
Okay, we have to screen them. It's clear, but is it from somebody from the family or totally strange?
Exactly. So I would like to say that maybe the best it's somebody from the neighbors, so from the family. Yeah, that's the best.